Good afternoon, one and all. Welcome to the afternoon session of Rapid Revision course, that is 2026. Moving ahead with our next speaker, can we have the CV? Yeah, our next speaker who is going to take the topic that is children management of the children with compromised medical condition. Dr. Sumaya Salim is an assistant professor of pediatric dentistry at Satyabama Dental College. She is an experienced pediatric dentist with more than 8 years of clinical practice dedicated to creating positive and child-friendly dental experience. Recipient of the prestigious ICMR grant for pioneering work of early childhood caries. She is a PhD scholar exploring and the topic is exploring microbial diversity and next generation sequencing in early childhood caries. She has received the award. She is an award-winning researcher and a speaker recognized nationally and contributed in the National Conference of Pediatric Dentistry and Dental Traumatology. She published several papers in national and international journals. I welcome you, Dr. Sumaya.
Thank you, sir.
Can we have recording?
Good afternoon to all the final year postgraduate students who are attending this virtual rapid revision conducted by Indian Society of Periodontics and Preventive Dentistry along with the Postgraduate Institute of Medical Education and Research, Chandigarh. So my topic for today is management of children with medically compromised conditions. And our branch, our specialty, pediatric and preventive dentistry, is never complete if we do not know how to treat a child with a systemic condition. This would be our table of contents, which we're going to see in this order, which would be definition, rationale of treating children with medically compromised conditions, classification, overview of the management, and system specific, along with how to present your answers for each of these conditions. So beginning with the definition, I've taken up two definitions from very well-known textbooks. So you can choose to write any one of them, or you can choose to write anything else from other textbooks as well. But I found these to be the simplest and easiest to understand, which says a medically compromised child is one with a systemic condition that necessitates modification of a routine dental care. And the other given in the pink ham is children with systemic disorders requiring altered dental management protocols. As simple as that. So we are going to perform the similar treatment which we do in any other child, but with a little extra care. The rationale behind treating children with medically compromised conditions is first to prevent any medical emergency during the dental treatment. We should also know to reduce the risk of infection, bleeding, or the delayed healing, which are more susceptible in any of the conditions. Modify dental care based on their condition, so tailor-made to their systemic condition. Minimize stress, anxiety, and pain during the procedure, and promote excessive and immense preventive oral care to generally improve their quality of life, and so that we need not have to do very extensive procedures, rather maintain it with preventive procedures. Broadly, if you can see, we can classify these medically compromised conditions into two things. One is system involved or based on our dental management considerations. Based on system involved, it can be cardiovascular disease, respiratory, hematological, the various, all the systems which we have. Based on dental management considerations, definitely which has more risk of infection, diseases which have risk of bleeding, that need drug modifications, or are stress intolerant, or which definitely requires special behavior management. Another way of classifying these conditions is hematological, cardiac, endocrine, neurological, and immune compromised. These are very broadly classified. Okay. So under this, we can have various conditions. As you can see, it could be the platelet disorders, congenital heart conditions. Based on function under endocrine, we have based on gland, based on etiology, such as diabetes mellitus, etc. Neurological, we have epilepsies, and we have also certain other special healthcare needs condition, and then immunocompromised, which could be either congenital or acquired, which we will be seeing in our further slides. So when we are going to look at management of medically compromised conditions, then we are going to have to know how to address this, right? So for that, you should know that there should be an overview of management, which means this is going to remain common when you write your answers for management of any medically compromised child, and also if you're going to treat a child in your clinical practice in the future. So these 6 categories are going to be common, which you have to know and assess in the same order, and then we will see system specific management as well. So starting with medical history. So for medical history, all you got to do is first we need to assess the patient, which means current condition of the patient, what medications they are taking, and what are the recent episodes of the systemic condition. And then we have to decide what type of behavior and how the pain control can be given for this patient. And if the treatment needs any modification, should we be very aggressive with the treatment plan, or could we do a passive invasive or non-invasive or a preventive treatment? And what all medical emergency should we be prepared for, and what could be the risk of contamination for the healthcare providers, and how we should be prepared for it. So a medical history is required to assess all of these. So from this book, which is one of my favorites book as well, the Scully's Handbook for Medical Problems in Dentistry, they have given a set of 25 questions where you can just keep it as a questionnaire and you can mark yes, no, or so. You can mention some of these questions in your answer as well as to what you will ask in a medical history based on the condition. Moving on to preoperative risk assessment. So when we have to take preoperative risk assessment, it is our golden rule, the golden grade 1 to grade 5 ASA classification, where we know that ASA, any patient who comes with an ASA 1 and 2, we do a routine dental care. ASA 3 and 4, we have a modified care or in a hospital setup. ASA 5 definitely is not going to be, if we won't do any elective procedures, it's only going to be emergency care. So you can remember this in an easier way. You can just remember this diagram. If we have to keep a speedometer kind of representation for ASA, then the green, blue, orange, and red. So we can keep ASA 1 as green, 2 as blue, 3 as orange, and 4 and 5 as red almost. So definitely we need to have a communication with the physician and the medical practitioner if you treat a child between 3 to 5 ASA grades. There is one more thing which we can take in forms of medical history, which are preoperative risk assessment. There is this table which is given in a book called this Dental Management of Medically Compromised Patient, written by Little, which says we can have this A, B, C, D, F, E, and F. So it is common again. What A stands for antibiotics, analgesics, anesthesia, and anxiety. B stands for bleeding, breathing, and the blood pressure. C for again capacity to tolerate any care and the chair position. D would be the drugs and devices. E would be equipment and emergencies, and F is follow-up. So for every condition, if we can just have these headings written, and for a cardiovascular condition, or for a hematological condition, or for a renal condition, or for an endocrine condition, if we can write which is applicable to this patient, then our preoperative risk assessment becomes much easier. Moving on to the third point, which is preoperative planning. So when preoperative planning begins, we have to think about what should be done before the treatment, during the treatment, and what has to be taken care after the treatment. So before the treatment, it all has to be who's going to come along with the patient, how are we going to communicate, the consent of the patient, does the patient require any specialized medication, such as for a hemophilic patient, we need factor replacement, and what special materials are required. All that has to be assessed pre-treatment. And during treatment, what are the vitals we are going to monitor? How much time are we going to take the procedure? If we are going to have any other help from their the child's medical team, etc. And post-treatment, post-operative care, how vigorously or how aggressively we're going to give it or instruct it to the parent or the guardian. That can be given in the post-treatment planning. Moving on to communication. So when we have to take communication, we have to communicate to the patient and the guardian and their healthcare providers, because it is a multidisciplinary approach when we treat a child with medically compromised conditions. So definitely from the patient and the guardian, we require the assent or consent or what would be the best principles which we can follow for maintaining their condition at normal during the treatment. From the healthcare point of view, we want to know what has been their health history in the last 6 months or 1 year. Should we be careful with any drug interactions when we prescribe any medications? How do we anticipate any excessive bleeding and antibiotic prophylaxis if required? And when is the ideal time for us to appoint the patient for a dental procedure? So when I say principle of best interest, when we talk to the guardian or the parent, the parents or the patient should show they have any previous evidence of they've been to a dental treatment, but procedure has not been done really well. Then do they have evidence of that? And what is the patient's background so that we can plan how comfortably or how stress-free environment we can keep during the treatment, and also the view of family members, because they also have to be on the same page for us to discuss a treatment plan. Finally, is the risk-benefit analysis. Whatever said and done, even if we are fully prepared to treat a child with a compromised condition, we have to weigh the aspects where is the treatment really necessary? Is it an emergency, or can it wait? Or should we stick to non-invasive procedures, or how? So this risk-benefit analysis is very, very, very essential before we start treatment planning for a medically compromised child. First thing is deferring elective care. As I said, we do not want elective care to be given at most importance. We want the child to be stabilized first. Only if the child is stable can we provide any dental treatment. So we can defer it as long as possible until the child is out of emergency or major health issues. Next, the history has to be updated. The medical history has to be updated at every visit. We cannot take it for granted that 6 months or 8 months back the child who had this history, so it's going to be the same. No, we have to update the history at every visit. Ensure oxygen is very accessible in our clinic and emergency drugs are readily available. Next thing is to follow standard precautions. We cannot compromise on what basic needs we have to give to the child as preventive treatment. Also, the standard precautions which we can take to prevent any medical emergencies. Definitely, and most important, informed consent before we start any treatment, and maintain privacy when communicating with your team or their own medical team and the physician and the parent or the guardian, to not let any patient information be used for granted. Last thing is to have a short and stress-free appointments. This stress-free word you would find in most of my slides, because in every standard textbook as well, the ending line for any condition would be to create a stress-free environment during the appointment, because any medical condition can get triggered when there is even a little bit of very unrest or not so calm environment during treatment. So definitely monitoring vitals throughout the procedure is essential, and anywhere between ASA 3 and 5, probably we're going to do it in a hospital setup. So vitals would be measured even more better in a hospital setup. So this risk and benefit has to be assessed for every patient, if actually the dental treatment is needed now, or can we wait for a few months or days before we begin the dental treatment. So to remember this, so again reinforcing this, so it says safe, stress-free and well-planned care is the key for treating children with medically compromised condition. I've just come up with a mnemonic to remember this. It'll be easy for you to write in your paper as well as for your practice in future. We can keep this as medical history, preoperative risk assessment, preoperative planning, patient and professional communication, and risk benefit analysis. So we can give it a mnemonic called MAP-R. Okay, so M from medical history, preoperative, A from the assessment, P from the planning, another P from the patient and professional communication, and risk benefit analysis. So probably it will help you remember this easily. So now moving on to system specific management. So here I want you to remember that any question is being asked in your exam to write on how would you manage a child with diabetes mellitus, for example, or a child with hemophilia. All you got to do is write a little bit of the condition, what is hemophilia, types of hemophilia probably, and certain oral manifestations, which we will be seeing in our slides, followed by the overview of the management, which we saw, the MAP for this condition, and then how specifically you have to remember to address the condition. That is what this whole presentation is about. So starting with the first system, which is the cardiovascular system. When we take cardiovascular system, the most common conditions are the congenital heart disease or the rheumatic heart disease. So congenital heart disease is what 8 in 1,000 live births, which is definitely seen. And rheumatoid heart disease is in a streptococcal infection. I think that's a spelling mistake, but yes, please excuse me for that. Streptococcal infection. And then the rheumatic heart disease, which is endocarditis, could be 40 to 50% risk in younger children. So the dental significance is that there are chances of getting infective endocarditis because of the bacterial infection. Stress intolerance. So if the patient is very anxious and a little uncooperative, so they won't be able to tolerate the stress, which will again trigger a attack for the already present cardiovascular condition. Bleeding. So they could be an anticoagulants. So we also have the risk of bleeding. So risk of infection, risk of bleeding, and the stress are 3 major factors in a cardiovascular condition. So if we take the oral manifestations of cardiovascular condition, it is cyanosis, clubbing, which we commonly see in our fingertips, the extremities, and then enlarged tongue. We might sometimes see dental enamel defects could be noticed because of the medication as well as the inherent change in enamel biology. Gingival inflammation, gingivitis sometimes, petechiae or purpura, and delayed eruption of teeth. And sometimes oral lesions can be noticed again due to increased the decreased microbial diversity as well as the infection, which is present by or a lot of medications intake, which leads deposits and some oral lesions, and lack of oral hygiene can lead to such conditions. So cardiovascular management can be of 2 types. One is prevention or management. So when we take prevention, so every textbook, even if you take McDonald, if you take Stuart Barber or this Richard Welberry or the Little's textbook or Scully, you will notice that there has always been prevention which is given. So a child in India, probably it's a little rare to have a preventive management, but definitely in most of the countries, what do they say? When a child is diagnosed with any systemic condition, the first and foremost is to start preventive dental management, which means regular visits for checking, reinforcing their dietary methods, the fluoride therapy, fissure sealants, oral hygiene instructions, regular monitoring, and reinforcement in every visit. So a very aggressive preventive regimen is important for a child with cardiovascular conditions. So this would be our first way to address the management, to have a preventive protocol. So now we go to management. So what are we seeing here? We're seeing the MAP-R here. So which means management has to be addressed in all these 6 headings. So next thing we'll write about in management of cardiovascular system is our recommendation of antibiotic prophylaxis. So when we take antibiotic prophylaxis, it is suggested when we are going to manipulate the gingival tissue or any periapical region perforation or of the oral mucosa, then we're definitely going to need antibiotic prophylaxis. But it is not suggested even if there was trauma to the lips or buccal mucosa. This is what it says, the guideline says. But I think that again is subjective as to what condition the patient is in, and we decide and take a call on whether we need to give an antibiotic prophylaxis or not based on severity of the condition. Antibiotic prophylaxis, yes, if a child has prosthetic valves, previous infective endocarditis, and very certain congenital heart conditions, yes, definitely it is required. The key principle is oral hygiene has to be reinforced first, which is very much necessary, and then followed by antibiotic prophylaxis. So we need to have a short, stress-free environment, and as I said, avoid unnecessary invasive procedures. It is not an emergency procedure or an urgent procedure. We still have dental care as an elective procedure. So we will take a call based on their severity. So this is the well-known antibiotic prophylaxis is given in our AAPD guidelines. And oral, if unable to take oral, then what? Then allergic to penicillin or ampicillin orally, then IV or IM, then allergic to again penicillin, ampicillin, IV or IM. What are we going to give? We have the child and adult dosage. It's self-explanatory. I think all of us have to remain incorporated in your answer as well. So to summarize this, if we have to take before treatment, definitely the medical fitness consultation is required. Check the INR, which is very, very important if there are anticoagulants. Pre-medication, if required, 1 to 2 is still good for an INR for a normal dental treatment. Pre-medication if required, so antibiotic prophylaxis, and how to reduce an anxiety to keep a stress-free environment during the appointments. Profound delay. Why are we saying profound delay? Because pain can trigger stress. So we do not want that to happen. So profound LA is required so the child is calm, and avoid excessive vasoconstrictor. So at least in children with cardiovascular system conditions, we better to avoid unnecessary use of or excessive use of vasoconstrictors, and asepsis, strict sterilized conditions and environment, and monitoring the vitals throughout the procedure. And after treatment, we are going to do the check on hemostasis and very aggressive post-op instructions, and a regular follow-up at least first initially 2 weeks later and then probably 3 months later. This is one example which I want you to give so after every system we will end up discussing this how to write or go by to mention an answer or your detailed answer for a condition. Suppose the question says, write dental management of a 4-year-old child with congenital heart disease. Assuming certain details, the child is 4-year-old. So first you will have to write what are the patient details, what kind of condition. You will not get such a very vague question. Probably it will only be very specific. It would be directly given as tetralogy of Fallot or a ventricular septal defect or anything infective carditis patient. So, but go through these headings which says the patient details, which means their history, what are they taking, what are their medical condition, then the dental history. If there has been any, have they have preventive measures? Do they have a dental home where they regularly visit? Bottle feeding? What was the history of bottle feeding, and are they still doing it? Or what is their diet, and how are they maintaining oral hygiene? Then comes our MAP R, which will assess all these 5 conditions. And then we have the current cardiac status. How are the vitals now? Any episode in the last 6 months, hospitalization in the last 6 months? How are we going to assess the risk of performing this treatment under general anesthesia? And what are the other things we have to keep in mind to have a stress-free appointment, such as risk of bleeding or risk of infection, and what medicines are supposed to be prepared with an emergency care. And dental features, assuming the child has early childhood caries, definitely behaviorism, uncooperative, high caries risk. How are we going to establish what comprehensive treatment plan will you do? But you have to keep in mind what all to write is the antibiotic prophylaxis stable, the chair-side management, which we saw in the previous slide, and definitely references for your answers. This also has been adapted from one of these textbooks. So based on that, you can tell. Most importantly, any teeth which is involving pulp are generally extracted. That is the guidelines according to AMPD and IMPD, that do not try to do a root canal and crown, because it's going to lead to infective endocarditis. It might lead to infective endocarditis. So it's better to remove the source of infection rather than treat it with a endodontic management. So moving on to hematological disorders. Hematological disorders are red blood cells based or white blood cell disorders, the platelet disorder, coagulation disorders. So most commonly, if we have to see, they lead to bleeding tendency, infection risk, delay in healing, a very important characteristic of this hematological disorders, and medical emergencies can happen chairside. So if you have to take the oral manifestations of these hematological disorders, gingival bleeding, spontaneous gingival bleeding, petechiae or purpuras, ulcers of mucositis, gingival enlargement sometimes, and the anemia also can have pale mucosa, vitamin deficiencies can have pale mucosa, and delayed eruption and certain enamel defects. So hematological disorders, if we have to take, this table is also there in the same book, Little's book, where again, now if you take all the A, B, C, D, E, F, if you can notice that for certain things we have written no issues, correct? So this would be a checklist for us to write for each condition. So allergies, no issues in case of hematological patients. Anxiety also not much of issues. Bleeding, no, in case of RBC disorder. So we're only talking about RBC disorder. So if I have to ask you for the coagulation disorder patient, then definitely bleeding, we would say yes, there is going to be some amount of bleeding based on which factor which is lagging, and factor replacement might be required. Breathing, blood pressure, no issues. Chair position, no issues. It's not going to affect our treatment plan. So this is how you make a checklist to do the risk assessment. So routine dental care should be deferred if the hemoglobin less than 11 grams for such patients already who have a medically compromised condition. Oxygen saturation is less than 91% and shortness of breath is present. You can also ask me that sometimes even normal people do have this, like hemoglobin is less than 11. Yes, that is okay, but that's not a burden for us. An individual who already has a medically compromised condition, definitely it's an added on burden. It's a risk factor. So we probably have to defer the treatment and we have done. So next would be anesthetic and drug considerations, which is we have to, the foremost important thing to remember is stress-free environment, appointments. So local anesthesia with epinephrine is okay, acceptable, not an issue, but avoid prilocaine or high dose alistates or aspirins, because aspirins again can trigger the bleeding tendency, barbiturates and narcotics. So preferred will be to give acetaminophen, that we always do. So plus or minus 49, the Western culture, but we do not have it, but acetaminophen is still okay. Nitrous oxide with greater or equal to 50% oxygen is indicated. I mean, it's not a contraindication. So, under sedation, it can be performed. And dental management is to prevent oral infection, remove the source of infection, and emphasize oral hygiene, caries prevention, and early infection control. Pulse oximetry is recommended throughout the procedure to monitor the vitals. So now, if we have to take to plan a treatment, we have to do a multidisciplinary planning. So then we also have antifibrinolytic therapy in case the bleeding doesn't stop. So we are risk of bleeding. Even a patient with hemophilia is also there. So then we have to work around first the hematologist or the physician who can help in assessing the bleeding disorder. And we have to tell them what type of dental procedure we are going to perform and what could be the expected bleeding and what are we looking at, what is the normal healing time and how can we expect it in this child. So when we have to take the action of antifibrinolytic agents in hemophilia, when there is an injury, immediate action is for us the inflammation to take place. vasodilation followed by vasoconstriction, right? So then when the clots form, then these the clots are really loose and stable. So fibrinolysis happens. Then these agents which are going to help in clotting of blood, such as the tranexamic acid, that's going to attach, that's going to strengthen these clotting fibers and prevent it from breaking down or fibrinolysis to happen. So this will help in the clot to remain stable. Another agent called the epsilon aminocaproic acid is also going to enhance these binds and prevents the plasmin from binding competitively, and thus prevents bleeding and helps in blood clot to be stable. So these are agents which is mandatory when we are treating a child with hemophilic condition. So the importance is that the clots are very fragile and dislodge easily. We definitely need an adjuvant therapy, which is the antifibrinolytic therapy. Now, in this hematological disorders, pain control can be achieved through analgesia, which is our common everyday use. It could be the sedation, and also in case if there's a risk of hematoma, which is generally seen in intramuscular injections. Normal preferred local anesthesia, preferably the intraligamentary or the pedal injections, and also along with nitrous oxide sedation is good enough to go. Definitely aspirate before injection and observe for hematoma formation post-operatively. So that generally blocks are to be avoided. Better to give intraligamentary or pedal or infiltrations for a local anesthetic procedure. And then preventive and conservative care, we should know. Preventive, it's the same for most of the systems. They are the gold standards for prevention: oral hygiene reinforcement, fluoride therapy, and dietary reinforcement, regular dental visit. Conservative, we can go for very minimal intervention dentistry, silver diamond fluoride usage, rubber dam isolations during very invasive procedures, and atraumatic techniques to prevent any minimal caries. So avoid soft tissue trauma, use a good suction and radiographs very cautiously, and pulp therapy preferred over extraction in case of hematological disorders, whereas it's the opposite in cardiovascular system. When we take the management of surgical ortho emergency, orthodontics, yes, all this is allowed. We can do our regular procedures, but avoiding sharp wires or gingival trauma is good. So probably aligners could be a good choice here. Then oral surgery, factor replacement before extraction is must. If the extraction is inevitable, we have to do an extraction to remove the source of infection. Then factor replacement. Which factor do you do? Factor 7, I think, should be used for hematological hemophilia A yeast and 1 milligrams. And then local hemostatic agents, which is liquid, and we can also use help of antifibrinolytics, which we saw in the previous slide. So just an example of how will you manage a child with hemophilia. We go through the same first 3 details will be patient details, dental history, and the MAP-R, followed by comprehensive treatment plan. But you will also mention the local anesthesia, the nitrous oxide sedation, what all should we remember, and the mechanism of antifibrinolytics. So we will do that to give a better healing for this patient and to provide treatment under normal stress-free environment. Moving on to endocrine system, which is diabetes mellitus. We're going to discuss on diabetes mellitus, which is a relative or absolute lack of insulin, an increasingly common disorder. It has 3 classifications, but we are more concerned about the juvenile one, which is insulin-dependent diabetes mellitus. When we take in juvenile diabetes mellitus, there is 2 things. Maximum, what can you worry about? It can either be hypoglycemia or it can be hyperglycemia. So hypo means decreased in the blood glucose level. So administer glucose orally if the patient is conscious only. Next thing is to administer glucose IV if the patient is unconscious with 50% dextrose or IM glucagon. Why we dentists should never attempt to give the oral glucose to an unconscious patient because aspiration of glucose into the lungs can happen. That will lead to another complication. So only if the patient is conscious, we administer orally. In case there is hyperglycemia, there are only symptoms which we should look for. The patient might be feeling excessively thirsty, frequent urination, fatigue or irritability. Stop the treatment then and there, postpone the treatment, maintain hydration with sugar-free fluids and contact their emergency care or if you have a team for emergency care. So when to defer the dental treatment is when the blood glucose is less than 70 milligrams. Okay, there is a risk of hypoglycemia. So we generally tell the patient to check the day they come for the dental treatment, and based on that we can decide to proceed or not or delay the treatment. Drugs and anesthesia, yes, local anesthesia with epinephrine or 1:1 lakh is safe. Acetaminophen for pain is good, but you can use the other things cautiously. If there are poor uncontrolled diabetes, then better to stay with chairside anesthetic and analgesic methods, and to reduce the infection because healing is going to be delayed in such patients. So oral infections have to be treated very aggressively. Don't do a passive treatment. Pulp therapy might not suffice, then do an extraction. Antibiotics if indicated, but better to take antibiotic prophylaxis before and after. And poor glycemic control is increased pre-post-operative infection risk. So this is what will delay the healing, and that can lead to further complications. Moving on to respiratory disorders, which is asthma. Asthma very commonly seen these days. So it is a chronic inflammatory obstructive airway disease by bronchospasm or mucosal edema or increased mucus secretion. It is a reversible airway narrowing. So it reverses with the medications given. It is prevalent 1 in 10 children, very common pediatric respiratory disorder. So what we should know when we are treating an asthmatic child is the frequency and severity of the attacks, the known triggering agents, the patient's last hospitalization for asthma, and the medications taken by the patient for asthma. So this has to be noted, and they would have a regular history and record book themselves. The oral manifestations we would see is high caries rate. The major reason is dryness of the mouth, the oral cavity, and also the inhalers, the puffs which they take could lead to demetallization of the enamel. So we reinforce the rinsing and brushing or wiping or gargling of the mouth after usage of medication. Gingivitis mild, high parental wart because they are predominantly breathing through their mouth and oxygen is not enough. So jaw growth altered, posterior crossbite, increased overjet, dry mouth. So majorly orthodontic manifestations are seen in one or two caries point of view. The key points to remember in treating asthma patients are late morning appointments because early morning they get this asthma attack. So it reduces the risk of any, precipitation of an attack on the dental chair. Avoid triggers in the operatory. Reduce strong odors, dust, methyl methacrylate, fumes, etc. So very sterilized, dust-free operatory for them. Ensure patient carries their bronchodilator inhaler and can be used prophylactically before the procedure. Monitor the respiratory status to know the volume of what is the child feeling, and pulse oximetry is kept throughout the procedure to know the vitals. And warning signs: if you find the pulse oximetry readings to be less than 91, we will try to have an emergency care by providing oxygen to the patient for a while and stop the procedure in 2. So stress and sedation, yes, we should remember, I kept saying stress-free environment, appointments. Then nitrous oxide can be preferred because oxygen is supplied to them. We'll avoid any narcotics or barbiturates, no depressions, no depressant medications to be given. And local anesthesia is we're going to have, they might have sensitivity to one of these sulfides which are present in the anesthesia. So probably without a vasoconstrictor, we can use an LA. Check for any allergy history if they already have one. And the drug concentration is okay. We generally avoid aspirin and SID. So our pain medication, which also has this ibugesic plus or ibuprofen based components are generally avoided. A normal acetaminophen is okay. And emergency care, beta-2 agonist inhaler should be present, and their own inhaler, whichever they are using. Oxygen support mandatory, and monitoring the saturation of oxygen has to be there, and emergency care should be ready for us to at our disposal. So if you have to manage a child, a 5-year-old patient with asthma, patient history, dental history, the MAP are, and consult with their pediatrician to assess for any of these symptoms in the recent past within 6 months. And then finally, a comprehensive treatment plan, keeping in mind all the precautions which we just said. Immunocompromised conditions. So immunocompromised condition is here I'm going to talk about HIV. Any chronic viral infection which can reduce our immunity, can suppress the immune system is immunocompromised condition. It can be transmitted to a child by vertical transmission, which is mother to child, blood products, and needle exposure. Predominant oral manifestations would be opportunistic infections because of the fungal growth or the viral load, increased caries risk, delayed healing, and it's the oral fungal and viral infections. So our challenges would be two things in case of immunocompromised condition, which is infection control and bleeding risk. So infection control, if you have to take risk of HIV transmission, hepatitis virus, tuberculosis infection, or other opportunistic viruses. So strict, sharp safety and universal precaution. So here we have a risk for the medical or the dental practitioner as well. So we have to have a post-exposure prophylaxis if a needle stick injury occurs is mandatory. And then the bleeding risk for the patient themselves. So we prefer intraligamentary injections or local infiltrations and avoid deep nerve blocks. Also, hemorrhage, risk of hemorrhage is present. So we always focus on preventive strategies. Never forget to mention that preventive strategies in your management, followed by dental emergencies where it will be prompt treatment of infections, any urgent care required at that point in time, infection control, and the major clinical tips would be the oral lesions. They might be the first sign for us to tell the progression or the current state of the HIV infection. And good oral health and nutrition is mandatory, but we do not have to have any discrimination in treatment. The same protocol has to be followed, keeping in mind, but extra infection control procedures. So this is the table. This table actually is present for all the conditions in this textbook. So if you want, I have given my mail ID there. If you want the soft copy of this textbook, I can give you that. But for this condition, again, if you see here, what all is written for an immunocompromised patients: anesthesia, no issues; anxiety, no issues; allergy, no issues. Others we have noted down. Chair position also no issues. Devices are no issues. None of the emergency cares are an issue. Blood pressure is not an issue. So rest, otherwise they have mentioned. So this is a very good checklist for every medically compromised condition. And lastly, we are going to see about the neurological disorder, which is epilepsy. And our tendency for recurrent seizures, only when a person has had 2 or more seizures are they considered likely to have epilepsy. So that frequency should be there for us to call a patient epileptic. So broadly classified as generalized and partial, tonic-clonic, or the simple and complex. So when we talk about seizures, major pre-treatment assessment is to know the type, frequency, and duration so that we are prepared for any seizure episode on the dental chair. And when was the last seizure episode? There are children with cerebral palsy who have seizure episode every day. Now, how do we do treatment for them? First, we have to figure out what are their emergency medical care. A consent has to be given as if the child has a pain and swelling, yes, that's a necessity for us to do a dental treatment. But if it's only an oral hygiene procedure where they have to maintain, then probably home remedies and the home care can be used or can be reinforced to maintain the hygiene. So drug concentration, yes, we notice some amount of bleeding tendency, gingival enlargement with their medications, but anticonvulsants may also cause this delayed healing and risk of infection. But we do not have a choice but to use it before our treatment. So schedule after an anticonvulsant intake only. Use of mouth prop if required. Local anesthesia is generally safe. And emphasize again, as I said, on preventive dentistry and oral hygiene. Very, 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 very important for a patient with epilepsy. So during a seizure, if the child is undergoing dental treatment and a seizure occurs during that seizure, stop the dental treatment immediately. Clear the instruments from the area and place chair in a supported supine position. So definitely, if we do not have a chair with supported arms or anything, then individuals or the assistants or the parents or the guardian have to be around the patient. Turn the patient to the side. Generally, they aspirate a lot of things. So lateral positions are advised and maintain airway patency. But in case after the seizure, what are we supposed to do? Once the seizure has stopped, provide oxygen. So oxygen has to be present in the operatory for emergency care. Suction the secretions which have the child has in the oral cavity. Assess for any traumatic injuries if possible. Monitor the vital signs and then arrange the a safe transport home. But when a parent has a child who has seizures every day, they are generally more experienced than us. But you can also maintain all the emergency care with the help of their own medical team in case we are doing an extensive dental procedure. So these are some of the previous year's questions from various universities. Predominantly asked one of these. We have tried to discuss most of them. And you can write your answer in the same flow. So at the end of this presentation, I would say all the best for your exams. And you just have to know the keywords. The flow in every answer has to be written for any topic, not just for this. And you can have key points mentioned and certain very characteristics, studies and authors which you can remember and the authors of certain books. And it's going to be fine. I think all of you will do well. But remember to keep certain mnemonics or key points that will help you formulate your answer. And this is my email ID. If you want any study material or books or any other articles which you would want me to send, then I can share it for sure. Please drop me an email. And all the best for your exam. Thank you.
Thank you, Dr. Sumaya. There was excellent compilation of the all the conditions. I know it is very difficult to cover this all the conditions in half an hour, but still you have managed to do that. I have seen that you have answered all the questions in the chat box also. So can we have a certificate, I mean, technical team? Dr. Sumaya, this is your certificate of appreciation from the ISPPD office for your all your hard work.
Thank you, sir.
Thanks a lot. Moving on to our next speaker. Our next speaker is Dr. Seema Thakur ma'am. Ma'am has done BDS and MDS from King George Medical College, Lucknow. She is currently working as a professor and head in the Department of Pediatric and Preventive Dentistry, HP Dental College and Hospital, Shimla. She is a life member of ISPPD, ISDT, Federation of Special Care Dentistry, and Indian Society of Cleft Lip and Palate and Craniofacial Anomaly. She is a recipient of the Best Presentation Award on pre-surgical nasolalar molding in ISPPD conference, Proficiency Award in KGMC, and Distinguished Woman Award by ISPPD. She has almost 100 publications in the various national and international journals. She has delivered a guest lecture in the and workshop on pre-surgical nasolalar molding in various national and international forum. Cleft lip and cleft. She is also a cleft lip and cleft palate board member of FSCD. We welcome you, ma'am. Right.
Thank you, SPPT, and thank you, PGI, for the opportunity.
Ma'am, we have your recording. We will play it. Just a minute.
Good afternoon, everyone. Welcome to the upcoming lecture of rapid revision. It is on the management of children with cleft lip and palate, with special emphasis on pre-surgical nasoalveolar molding. We pediatric dentists treat not only children, but are skilled in the dental management of special healthcare need patients. Cleft lip palate, which is the most common congenital anomaly of head and neck region, requires a special attention as most of its management requires our skill. The worldwide presentation of this anomaly indicates that it is least common in African American population, whereas it is most common in Asian population. In India, its incidence is 1 in 781 live births. Clefts affect not only appearance but also function, and management of cleft lip and palate requires a multidisciplinary team approach for the optimum results. The cleft lip palate team include pediatrician, pediatric dentist, plastic surgeon, speech therapist, ENT surgeon, oral surgeon, orthodontist, prosthodontist, psychologist, and last but not the least are the parents, because their constant motivation and guidance is required, and their support is required for the optimum results of these patients. To ensure the results are consistent and measurable, we must align our team's effort with the gold standards of comprehensive cleft care, specifically those adapted from the American Cleft Palate Craniofacial Guidelines. In these guidelines, emphasis is placed on the coordinated, family-centered, and long-term care. It is based upon the following core principles. Management requires an experienced interdisciplinary cleft team. Team should maintain adequate patient volume to preserve expertise. An evaluation of the patient is recommended within the first days to weeks of life. Families should be actively involved in the informed decision making. Support for psychosocial adaptation is an essential component of care. Long-term management may involve audiology, pediatric dentistry, or orthodontics, genetics and dysmorphology, nursing care, oral and maxillofacial surgery, otolaryngology, pediatrics, plastic surgery, psychology, and speech and language pathology. Emphasis is placed on the coordinated and comprehensive care. Care should be coordinated through the cleft team and delivered locally whenever feasible. Management should respect cultural, psychosocial, and individual family needs. Continuous monitoring of treatment outcomes and quality improvement is essential. Long-term follow-up is necessary throughout growth and development. Multidisciplinary sequencing of treatment in clefts involves a coordinated age-wise continuum of treatment. Therefore, major treatment procedures can be divided into 4 stages for convenience that corresponds to the child's dental development. The stage 1 starts from birth to 18 months of age. The stage 2 corresponds with the primary dentition stage, that is 18 months to approximately 5 years of age. And stage 3 corresponds with the late primary and mixed dentition stage, that is from 6 to 11 to 12 years of age. And stage 4 is that of permanent dentition stage. Starting with the stage 1, that is from birth to 18 months of age. The stage 1 from birth to 18 months of age involves multidisciplinary management aimed at addressing psychosocial issues, feeding management, feeding obturators when required, monitoring of ears and hearing, and pre-surgical infant orthopedics, including the pre-surgical nasoalveolar molding, timely repair of cleft lip and palate, and early assessment of speech and language development, thereby establishing the foundation for normal growth, function, and rehabilitation in the cleft child. Beyond the physical deformity, the birth of the child with cleft lip and palate often brings significant emotional psychosocial stress for the parents and family. The core parental anxiety is associated with feeding difficulties, appearance, surgery, speech development, fear of the birth of next child with the same anomaly, and the child's future well-being. Parents have the anxiety regarding intellectual growth of the child, social integration and peer reaction, financial implications involved in the treatment of the child. The pediatric dentist is usually the first dental specialist to meet the family. This early meeting is critical for establishing a roadmap for long-term clinical and psychological rehabilitation. Support and counseling goals include to negate fear and guilt through empathy, provide detailed treatment information to the patients, foster parent confidence and nurturing skills, and address psychosocial issues from the onset. Using the photos of treated patients helps parents visualize a positive future and reduce the immediate anxiety. One of the earliest and the most immediate concern faced by the parents of infants with cleft lip and palate is difficulty in feeding and maintaining adequate nutrition. Feeding difficulties form one of the earliest functional challenges in infants with cleft lip and palate. To understand the basis of these problems, it is important to first compare the normal feeding mechanism with the altered feeding pattern seen in cleft patients. During feeding, in a normal infant, the soft palate moves up and closes the nasal passage from the mouth. This creates a closed system inside the mouth, allowing the negative pressure to develop and milk to flow. In a cleft palate infant, the soft palate does not move up and cannot close the nasal passage from the mouth. Therefore, a closed system cannot be created and negative pressure cannot be generated. The infant with cleft palate may look like he is sucking, but he cannot generate negative pressure to draw the milk. This leads to ineffective feeding and poor weight gain. Feeding problems are the immediate problems that the parents of complete cleft lip palate infants face. Feeding difficulties can be threatening to new parents, often leading to self-doubt in their nurturing ability. These problems include insufficient suction to pull the milk from the nipple, excessive air intake during feeding, choking, nasal discharge, and excessive time required to take the nourishment. Immediately after the birth, nutrition is provided with the help of nasogastric tube. However, it cannot be used for a longer period due to the associated complications with it. Therefore, there is a need for the early intervention by conservative means to manage difficulties. Cleft lip palate baby can be fed by trained breastfeeding, modified bottle feeding, spoon feeding, syringe feeding, and with the help of feeding plates or feeding obturators. Some babies can usually be breastfed with proper nipple positioning and breast compression. Baby is typically placed in semi-upright, straddle, or football ball position, and mother must ensure that the baby has a good latch. There are many modified bottles available in the market for feeding these children, like Medulla, Haberman Special Needs, Cleft Palate Nursel, and the Cleft Palate Bottle by Pigeon. The common feature in all these bottles is that these bottles are compressible and these bottles have relatively a longer teeth. Normal bottles can also be supplemented by modified teats available in the market. The other methods which are used for feeding these children are spoon feeding and syringe feeding. With syringe, the milk is gently flowed into the buccal space to time with the baby's suck swallow teeth pattern. But both of these techniques are very slow and time consuming. However, these are quite helpful after the lip and palate surgery. Then comes the feeding with the help of feeding plates and obturators. These are specially made dental plates to assist feeding. Feeding plates conform to the shape of hard palate and provides a seal between the nasal cavity and oral cavity. It also reduces nasal regurgitation and incidence of choking. These are custom made and helps to assist in bottle feeding. If used in first 2 to 3 days of life, has been shown to establish breastfeeding. These plates are fabricated using clear acrylic self-cure resin and thermoform acrylic silicone material. A floss is used to secure the feeding plate. The plate is removed after every feeding and is stored in moist container. The feeding plates are required to be changed after 4 to 6 weeks to accomplish the palatal growth. Then we also need to guide the feeding pattern we also need to guide the parents regarding the feeding pattern for these patients. The parents should be told to hold and nurse their infants so that increased bonding occurs. Child should be kept in a semi-upright position. Gravity will help to prevent the milk from coming through the baby's nose, and it limits choking and moreover decreases the risk of middle ear infections. Infants with cleft lip and palate tend to swallow a lot of air during feedings even when they are fed in an upright position. Child should be made to burp regularly during and after feeding. Then comes the most important component of this stage, that is pre-surgical infant orthopedics, or including the pre-surgical nasoalveolar molding. The wider and extensive clefts as seen in complete cleft lip palate cases are deficient in hard and soft tissues elements and pose a significant surgical challenge to achieve functional and aesthetic outcomes. Ideally, these deficient tissues should be expanded and malpositioned structures should be repositioned before surgical correction, all allowing for a less invasive surgery to the patients. This design to reduce the surgical challenges of cleft lip and palate led to the advent of pre-surgical infant orthopedics. Pre-surgical infant orthopedics is an umbrella term that covers any treatment of an infant's cleft deformity before the definitive primary lip surgery. There have been numerous techniques documented over the centuries to improve the position of the cleft alveolar segments. The early evidence of surgeons' attempts to reduce the severity of the deformities before the primary surgical repair to achieve a better outcome came as far back as the 16th century. In 1686, Hoffman described the use of head cap with arms extended to the face to retract the premaxilla and narrow the clefts. In 1719, Dassault used a similar technique to retract the maxilla in the bilateral clefts. In 1686, Hoffman described the use of head cap with the arms extended to the face to retract the premaxilla and narrow the clefts. There have been improvements to this method of using the head as an extraoral anchorage. In 1844, Hurleyhan stressed the importance of pre-surgical preparation of clefts using adhesive tapes binding. As Mark and Kowalczyk used a bonnet and strapping to stabilize the premaxilla after surgical retraction. Brophy demonstrated passing of silver wire through both ends of the alveolus and tightening to narrow the clefts. The concept of intraoral device to reposition the clefts alveolar segments is attributed to McNeil. Through a series of acrylic plates, the segments were actively molded into their desired position. Buster popularized this technique. However, in 1975, Georgette and Latham introduced a pin-retained appliance to simultaneously retract the premaxilla and expand the posterior segments over a period of days. In response to the controversies associated with active retraction of premaxilla, Horst described the use of passive orthopedic plate to slowly align the cleft segments. All of these appliances were designed to correct the alveolar cleft segments only, despite the fact that the cleft nasal deformity remained the greatest aesthetic challenge. Later on, in 1993, Graysons et al. Came up with a technique to correct the alveolus, lips, and nose in infants born with cleft lip and palate, and this was pre-surgical nasoalveolar molding. Now, this molding of cartilage for pre-surgical nasoalveolar molding was based on the research of Masso et al. In 1984, Masso et al. Described a technique to non-surgically correct congenital auricular deformities, taking into the advantage of plasticity of the infant cartilage. He believed that the high level of estrogen at the time of birth leads to the increased hyaluronic acid that inhibit the linking of the cartilage into cellular matrix. As a result, the cartilage in the newborn is soft and lacks elasticity. The level of estrogen begins to decline immediately after the birth, and a state of elasticity eventually sets in, and maintaining the shape of the nasal cartilage at that point. PNAM is, in a simple language, we can define the PNAM as a non-surgical method of reshaping the gums, lips, and nostrils before cleft lip and palate surgery, thus lessening the severity of the cleft. Basically, this pre-surgical nasoalveolar molding appliance consists of three components. The intraoral component, that is alveolar molding appliance. Second component is the retentive button, and third is the nasal stent. This is used for the molding of the nasal alar cartilage. The intraoral alveolar molding appliance is of uniform thickness and is made up of self-cure acrylic resin. A hole of approximately 5 mm in diameter is made through the palatal surface to provide a continuous flow of air should the posterior border of the plate lose a retention and rotate down towards the tongue. The retentive button is made on the anterior-inferior region of the molding plate at an angle of 35 to 45 degrees to the imaginary occlusal plane. It helps in the positive seating of the appliance and helps in securing the retentive elastics when the retentive tape is applied on the cheeks. The nasal stent is added when the alveolar cleft is 5 millimeter or less. It is made up of 19 gauge stainless steel wire. There is one retentive button and one nasal stent for unilateral cleft lip palate deformity, whereas for bilateral cleft lip palate deformity applies, there are two retentive buttons and two nasal stents. Now, this intraoral appliance is secured extraorally to the cheeks bilaterally by the retentive surgical adhesive tapes wrapped around an orthodontic elastic at one end. The elastic then engages the retentive button. A well-finished plate is lured with minimal molding activation to ensure a good fit and to allow the baby to adjust for the first week. Then comes the appliance molding. The alveolar molding is achieved with the help of gentle forces delivered to the alveolar segments by the orthodontic elastics attached to the molding plate and by reciprocal addition and subtraction of the hard and soft acrylic to the molding plate to achieve the normal curvature of the arc and to reduce the alveolar cleft. The nasal molding is achieved with the help of nasal stent. The nasal stent can be activated by the wire or can be some soft acrylic can be added to the nasal component of this nasal stent. Post-operative care for this appliance is following the delivery of the molding plate, a 1 to 3 day adjustment period for both the infant and the caregivers is to be expected while each adapts to the life with nasal molding appliance. Parents are instructed to keep the plate in full time and to take it out for cleaning as needed. Elastics should be changed every day. Appointments for adjustment of NAM appliance should be performed every 1 to 2 weeks. And treatment is usually completed within 4 to 5 months. Now, coming to the benefits of this technique, PNAM reduces the number of surgeries and need for alveolar bone grafting, hence saving the child from pain and psychological trauma. The process is cost effective, the results are far more aesthetic. Serves a dual function by acting as a feeding appliance. There is no need of any other additional feeding appliance. That alveolar molding segment of this appliance acts as a feeding appliance. Another important benefit of NAM is the opportunity for the parents to actively take part in the rehabilitation of their child. PNAM is an effective method for the improvement of nasal symmetry in complete unilateral cleft lip palate infants, and various studies, including the studies conducted in our department, also verifies this. In long term, the studies indicate that the change in nasal shape is stable with less scar tissue and better lip and nasal foam. This improvement reduces the number of surgical revisions for excessive scar tissue, oronasal fistulas, and nasal and labial deformities. With the alveolar segments in a better positions and increased bony rigid bridges across the cleft, the adult teeth have a better chance of erupting in good position with adequate periodontal support. One of the major limitations of this process is that it requires a high degree of compliance of parents during treatment, and it may not be practical in situations where parents must travel a great distance for a weekly care, as multiple visits are required for the whole treatment. The next component of this stage is primary lip surgery and palatoplasty. The chyloplasty or primary lip surgery is performed at the age of 3 to 6 months. It improves the infant's appearance, relieves parental apprehensions, and enhances their acceptance of the child. Various types of lip surgeries are Millard's repair and Tennyson-Randall repair. Rule of Tennyson important criteria for lip repair. It states that at the time of surgery, the age of the child should not be less than 10 weeks of age, have no less than 10 grams of HB, and should weigh at least 10 pounds, that is 4.5 kgs. Closure of the palate is accomplished by 12 to 18 months of age, as this correlates with the age at which most of the children begin to talk. At this time, collaborative team approach of speech therapist and ENT specialist is required. Plasty also improves the hearing and swallowing. Next comes the stage 2, that is the primary dentition stage. Here, the treatment is initially focused on establishing and maintaining oral health to reduce the possibility of the development of dental caries. Ectopic eruption of the primary maxillary anterior dentition may also lead to dental caries. Management of cleft-related speech problems are also done in this stage. Young patients with cleft lip and cleft palate often have associated middle ear infections and consequent hearing difficulties. These children may have a history of frequent courses of antibiotics for repeated ear infections. They may be under the care of ENT surgeon and required to be operated under general anesthesia. It is required to obtain full details concerning the child's prescribed medications. Administration of sucrose containing medicines can give rise to dental caries, and it is essential to explore the possibility of sugar-free alternatives in these cases. Parents may be nervous to brush in the region of clefts, especially following primary lip and palate surgery. They often think that the bleeding from the gingival inflammation is caused by damage from toothbrushing or breakdown of surgical repair. Parents should be shown in detail how to brush the teeth and gums properly. It is important to point out the potential problem areas of plaque accumulation around the teeth in the cleft region. Where the upper lip has been repaired, parents should be shown how to lift, stretching the lip carefully by sliding an index finger along the labial gingiva without doing any damage to the scar. This helps to give them a clear view of the cleft region with a good access to the crowns of the anterior teeth and the gingival margins for plaque removal. For the toddlers, parents are advised to stand or kneel behind the child when brushing, with the chin supported and head resting against the parent's chest. A low fluoride children's toothpaste containing no more than 600 ppm fluoride is recommended for children under 6 years of age. However, the children with high risk of developing caries should use a standard toothpaste that contains 1000 ppm of fluoride. Parents should be given the opportunity to practice the toothbrushing technique in the operatory. A twice yearly professional application of topical fluoride varnish is also recommended for these patients. Now comes the cleft-related speech considerations. Children with an unrepaired cleft palate are not able to separate the nose from the mouth. Even after surgical closure of palate, some children are unable to create adequate intraoral pressure for normal speech. Any problem with the child's ability to separate the nose from the mouth during the speech is called velopharyngeal dysfunction and velopharyngeal insufficiency. The speech and language assessment should take place regularly. Some types of VPT can be treated with the speech therapy alone, and other types of VPT requires a surgery or prosthesis. A speech prosthesis is a removable appliance that is attached to the teeth with wire clasp and is fabricated by a dental specialist in conjunction with a speech language pathologist. The design of the prosthesis is determined by the instrument VPT evaluation, and its fit is modified and fine-tuned as needed. There are two types of speech prosthesis, lifts and obturators. Palatal lift appliance lifts the palate in order to close the velopharyngeal gap. An obturator closes the velopharyngeal gap with an acrylic bulb that matches the gap size and shape. Due to the significant improvements in the surgical approaches for the treatment of VPI, many teams no longer use obturation as a treatment modality. The various advantages of this speech prosthesis is that in young child, it allows the development of correct sounds. The speech bulb is infinitely adjustable in size and shape. It is removed at night, so it does not cause any obstructive sleep apnea. So prosthetic treatment provides a reversible trial for controlling VPI before committing the child to a surgical procedures. And prosthetic treatment makes control of VPI available to patients for whom surgery is not possible. The disadvantages are requires parents' commitment, patient compliance, and professional skilled at working with children. Initial desensitization needed to reduce gag reflex. Requires modification as child grows. Requires many office visits for development and adjustment. Long-term presence of any removable dental prosthesis makes oral hygiene difficult and increases risk of cavities and periodontal problems, and this appliance can be broken or lost. Next comes the stage 3, that is the primary or mixed dentition stage. It starts from 6 years to 12 years, approximately 12 years of age. During this stage, the problems are ectopically erupting permanent central and lateral incisors, and crossbites of posterior dental segments. The treatment modalities for correction of developing traumatic occlusion in the posterior segments are maxillary expansion, that is followed by alveolar cleft bone graft. This graft provides a bone support for the teeth adjacent to the cleft, provides bone through which the teeth can erupt. It offers a maxillary arc continuity, aids in closure of the oral nasal fistula, supports the alar base of the nose. The timing for grafting this bone should be grafted in the cleft before orthodontic tooth alignment is begun. When the cleft is filled with normal viable bone, the orthodontist can proceed with the tooth alignment without fear of exposing the root surfaces into the cleft side. The bone graft should be placed between 9 and 12 years of age, when the canine root is 1/4 to half formed. Next comes the permanent dentition stage. Some patients in this stage, some patients require conventional orthodontic management, and some require the combined orthodontic and surgical approach. Most orthodontic surgeries involving the maxilla and mandible are deferred until the teenage years, when the maximum growth of the jaws has been attained and all the permanent teeth except the third molars have erupted. In boys, delay osteotomies until approximately 17 to 18 years of age. In girls, it can be deferred by 8 to 15 years of age because of the early maturation of the girls. The cosmetic surgeries like nasal bone surgery and surgical lip revision can be deferred when the growth is completed and when the orthodontic treatment is completed, so that there is a proper bony support, bony dental support for the upper lip before all these surgeries can be undertaken, and the clear picture is available what has to be done for the cosmetic surgery. Now, finally, to conclude, I would say that the role of pediatric dentist starts from the neonatal period right up to the permanent dentition phase. Pediatric dentists perform a dual role in both improving the personal impact as well as improving the surgical outcome. Throughout the treatment planning, patient support and skillful behavior management are important aspects of this multifaceted care. The most likely questions from this topic are on the role of pediatric dentist in the management of cleft lip and palate patients, notes on pre-surgical infant orthopedics, as well as notes on pre-surgical nasoalveolar molding, role of pediatric dentist in the rehabilitation of cleft lip palate infants during the first year of life, as this is the, I think that most of the treatment, many treatment processes are undertaken during the stage 1 only of the child, that is from birth to 18 months of age. Next question that is commonly asked is the note on the feeding management for cleft lip palate babies, and question on speech processes that includes its advantages and disadvantages. These are my references, and thank you for the patient listening.
Thank you, ma'am. Thank you for your excellent and informative lecture. Ma'am, there are few questions in the chat box. Uh, Ma'am, are you there?
Yeah. Actually, I was just responding to those questions only. The chat
Okay,
box
okay.
itself.
Should I read them, or you want to respond in the chat box, ma'am?
Yeah, I
As
have
per your
already responded to most of the questions, but there is another question. Any special consideration regarding the obturator for soft palate cleft in peri-Robin sequence patients? Actually, generally for, as I have mentioned before also, for the soft palate clefts, generally there is no need of obturators. We don't give obturators for the soft palate. Though we do give the speech appliances if they are required. Otherwise, there is no need of the obturators for soft palate clefts, especially if they
Okay.
are the small one.
Thank you, ma'am. Thanks a lot, ma'am. Can we have certificate, ma'am, certificate on the screen? This is a token of appreciation. Certificate from ISPPD.
Thank you so much.
Thank
Thank you
you,
so
ma'am.
much, Team PJ and ISPPT for the opportunity to interact with the residents. And this is a great initiative by all of you for the residents who are preparing for their exams, and other residents as well who are not preparing for their exams, and definitely they must be learning a lot from these lectures. Thank you so much.
Thank you, ma'am. Thanks a lot, ma'am. Moving on to the next speaker, Dr. Rigzin. Dr. Rigzin Tamuch has completed his BDS from the Government Dental College, Srinagar, and MDS from MDS from AIMS, New Delhi. He pursues post-graduation training in AIMS and gain expertise in the pediatric dental care, preventive strategies, and evidence-based practices. He was a senior resident at PGMAR Chandigarh. Currently, he is working as an assistant professor in pediatric and preventive dentistry at AIMS, CAPFIMS, New Delhi, contributing in teaching and patient care. He's published multiple international research papers focused on infants with Pierre-Robin sequence, cleft lip, cleft palate, and children with special healthcare needs. Dedicated to advanced modern pediatric dentistry, he served for excellence through innovative research, compassionate treatment, education, and improved standards. We welcome you, Dr. Rigzin. You need to unmute yourself, Dr. Rigzin.
Thank you, sir. Am I audible, sir?
Yeah.
Okay, sir. I have uploaded the video. Can you
Yes,
play it
yes.
for me, sir?
Yeah,
Okay,
yeah.
sir. Thank you.
Hello and good afternoon to everyone. Today, I'm going to present a topic on odontogenic cysts and tumors, especially among pediatric patients presented to dental clinics, and how to approach if any question comes in your final paper regarding the odontogenic cysts and tumors. So, moving forward, I'll be going through the following contents. Learning objective of this presentation is that by then we should know the WHO classification given in 2022 and what are the most common odontogenic cyst and tumors that are presented in children to the dental clinics, and how do we check on the clinical findings, the radiographic, the differential diagnosis, and at the end, how do we manage those cases. Now, coming to the introduction, what actually is a cyst? Cyst is a pathological cavity that contains fluid, semi-fluid, or a gaseous content, and is not merely a presence of a pus. So, if there is a pus present, then we could say it's an abscess. Most of the cysts, but not all, are lined by the epithelium. If it's lined by the epithelium, such as dentigerous cyst, we could call it is a true cyst because it's lined by epithelium. And the other term is a pseudocyst, which are the cysts which are not lined by the epithelium, such as solitary bone cyst or an aneurysmal bone cyst. Now the question arises, where do these odontogenic cysts comes from? So after the epithelial remnants or the tooth germs, it has formed the enamel or dentin or a pulp, then the most of the cell rest, they remain as such normally in the jaw. So these are the cell rest of molasses, the dental lamina, and the reduced enamel epithelium. So unless and until they are stimulated by a certain kind of cytokines or some infection or all, they stay dormant. Once there is any inflammation, it can start proliferating and give rise to the cyst formation. Now, next important thing is the classification. We had a classification in 2005, 2017. Then the recent one is WHO classification 2022. So now initially in 2017 they had the cyst classified in inflammatory and the developmental one. So now they have gone away with those terms and they have put the cyst under one umbrella in the name of cyst of jaws. So in this presentation, I will be going through one of the most common form of the cyst, that is the radicular cyst, dentigerous cyst, and the odontogenic keratocyst. And the next is the odontogenic tumors, based on their formation, the orogenic tumors are classified based on whether they are epithelial origin tumors or they are mesenchymal origin orogenic tumors, or they can be a mixed of both epithelium and mesenchyme. And the last is the malignant orogenic tumors that we don't see very common in the children. So I will be going through the most common orogenic tumors like adenomatoid orogenic tumors or ameloblastoma, specifically the unicystic one, and the odontoma, which are most commonly presents in the children and adolescents. That is of interest for the pediatric dentist. So going forward, what is the main difference between the classification of 2017 and 2022? So I have already mentioned that initially they have divided the cyst in inflammatory origin or the orogenic or non-orogenic one, and now they have gone away with those terms and they have placed the cyst of jaws in a common umbrella term and without any subdivision. Now going forward, how does the cyst develop? So what happens is most of the time when there is kind of infection or a gene defect that causes the release of some kind of cytokines that stimulates the dormant cell rest that are present in the jaws. And once it proliferates to certain number of cells, and as they proliferate, the cells from the central site goes further and further away from the blood supply, and what happens is they don't get enough nutrition, so they go autolysis and they release their inner cell contents, and the cell contents of this are hypertonic, and what it does, because of the almost osmotic gradient, it pulls more water into the cyst itself from the surrounding areas. And as the pressure increases, the lining which are present around the cavity, it becomes a thin layer of around 5 to 10 layers of cell which forms the cyst lining cavity. And how does now the volume increases? What happens is the most of the cyst, they secrete lots of proteins, something like keratin and all, and it further increases the osmotic gradient and it starts expanding. By far, what happens to the bone is that when there's a pressure to the bone and it secretes most of the prostaglandins and it stimulates the ranchial system, that also activates the osteoclast and it further increases in the size. So now, before going forward, I would be discussing the most common management of the cyst according to the parts 1 and parts 2 that we have been studying for in our undergraduates and all. So before the antibiotic era, there was the most common practice was to marsupialize it, then after decompression or marsupialization, then enucleate it. And enucleation can be done through oral cavity, nose or antrum. Then after the advent of antibiotics, more commonly they have shifted from the conservative treatment to more aggressive one, in where the treatment can be done in a single go so that patient don't have to come again and again and have to come for a long follow-up. So in the past two, what we do is enucleate and do the primary closure, and if there is aggressive lesion, then what we do is we enucleate it, then primary closure can be done with a reconstruction or a bone grafting. So by far, we should understand what is the difference between the decompression and a marsupialization. In decompression, what we do is we just create a stoma in the cyst and we just put a drainage tube and we don't do anything to the lining. So what happens is, because of the drainage, the stoma, the cyst, internal cavity pressure decreases and it becomes smaller, so that we are able to do a enucleation of the cyst lining after some point of time. And the difference between the marsupialization and decompression is that in marsupialization, what we do is when we find the cyst lining, we create a stoma around 1 centimeter. Then we stitch the lining of the cyst with the oral mucosa, and then we keep the patient on follow-up. When it becomes smaller or is away from the nerve bundles or a tooth, then we enucleate altogether. Now we will be discussing the most common cysts that we come across in our day-to-day pediatric practice. So most common is the radicular cyst. It is an inflammatory cyst usually associated with a non-vital teeth. So whenever there is a non-vital teeth and cyst around it, we should always think of first as a radicular cyst because it is one of the most common cysts. It represents around 60% of the total cystic lesions that present in the oral cavity, and it originates from the cell rest of molasses that are present in periapical region once the tooth has formed, and it lies dormant. Because of the infection of the cytokine, it stimulates it, and the cell rest of molasses start proliferating, and the process we have already discussed. How does the cyst develop? So this is how it forms the cyst. Now, some of the times what happens is we have extracted the tooth and we have removed the cyst, and sometimes the remnant of cyst can also lie in the periapical region, and we call it as a residual cyst. It's not very common thing that we come across. So when there's radicular cyst, we should always look for a carious tooth. And why? Because carious tooth, because it's one of the most common cause of the radicular cyst is caries, because we know that prevalence of caries is very common, especially in children. And so we'll be discussing in the next slides that lesion as such in this lesions like radicular cyst does not produce much of symptoms. And what happens is most of the time, many times children present it to the dentist with a pain in some area, and when we do a OPG, we find radiolucent areas around the lower premolar areas, and then when we ask the child, do you have a pain, then they may say they never had a pain. So this is the insidious kind of cyst that we come across, and it can cause a swelling or a pain once there's a secondary infection. If it gets secondary infected, then it could cause a pain, and it could also cause a jaw swelling. And if the jaw swelling is more, then we could feel that if it has perforated the cortex, then we can feel it is an eggshell crackling sound in this kind of radicular cyst. Now, when we do the imaging such as IOPA or OPGs, we could see that the radiolucency is well defined with a thick or radiopaque cortication, and some of the times if we say if there is thick cortication is absent, it can be because that cyst has been infected and patient may present with a symptom. So that time we don't expect that to see a cortication. And most of the times we can see that it can displace and resolve the adjacent tooth and also cause the expansion of the cortical plates. This is the thick cortex that we can see. Now, what are the differential diagnoses of radicular cyst? The differential diagnosis of the radicular cyst, it can be periapical granuloma, an initial stage of periapical cementitious dysplasias, the depression of salivary gland depression, especially in anterior mandible due to the sublingual gland, and posterior mandible due to the salivary gland depression, specifically the submandibular one, and idiopathic bone cavities could be differential diagnosis. So before we have done the radiographs, we have checked the clinically, and for the diagnostic test, we should always go first with the pulp test and radiographs. So pulp test is required because most of the time the radicular cyst is usually associated with a necrotic tooth. So what it does, it gives you an idea that it could be a radicular cyst. And aspiration is the one common diagnostic workup that we do every day in patient coming with a cyst. So what we do is we take a 10 to 20 ml of syringe with 19 gauge needle, and we prick it in the most dependent part, and then we can see that in the radicular cyst we can see the cholesterol crystal with glistening yellow, and when we do the protein analysis we could see that protein content is around 15 to 11 gram per 100 ml. Now, how do we manage these cases? If tooth is salvageable, specifically in a permanent tooth, we can go for orthograde RCT. Then we open up the flap and remove the cyst as much as we can. Then we can do a retrograde filling with MTA, and then we can keep the patient on follow-up. If tooth has to be extracted, then we should make sure that we enucleate the cyst as such in a single procedure. As far as primary teeth is concerned, we mostly go for extraction because most of the primary cases present like this with grossly decayed primary molars. First, we remove the tooth, then we tend to marsupialize it with the surgical stent. We place it the surgical stent, and we want the tooth to erupt in its arch in anatomic position. Now, the second most common cyst that we come across after the radicular cyst is the dentigerous cyst. The radicular cyst represents among 80%, and the second most common orogenic cyst, it represents around 18% of the total cyst that we come across. Now, the dentigerous cyst, it arises from the dental follicle of an unerupted tooth or a developing tooth. It is formed basically because of the fluid accumulation between the reduced enamel epithelium and the crown. And it's most commonly seen in the second and third decade of life, and it has predilection towards male compared to that of female. Now, most commonly seen associated tooth are the mandibular third molars, followed by the maxillary canine, then maxillary third molars, and then at last the mandibular secondary molars. So it is also not painful like radicular cyst unless secondarily infected. It can be presented as three types based on the location in the respect to the relation of the crown. It can be either central, lateral, or a circumference. Now, coming to the imaging features of dentigerous cyst, we can see the image, radiographic image of a dentigerous cyst as a well demarcated, corticated, or a unilocular. It's a single one that is attached around a CJ. So we have to know the difference between the dentigerous cyst and the follicular space. Follicular space is usually less than 5 mm. It doesn't exceed more. So if it is more than 5 mm, then we have to think of it as a radicular cyst. Now, how do we differentiate in cases such as this, where the tooth is carious and there is a presence of a unilocular radiolucency and it mimics a radicular cyst? So we will always have a confusion in this type of presentation because it looks very similar to the dentigerous cyst because of the presence of the succedaneous tooth. So whenever we look at the radiograph, we have to make sure that we look properly at the CJ. Radiograph, we can see that it is not attached to the CJ and is going beyond the crown. So we could say that it's mostly a radicular cyst rather than a dentigerous cyst. Now the differential diagnosis would be a unilocular OKC and unicystic ameloblastoma, or ameloblastic fibroma in a teenager where it's radiolucent. And anterior maxilla, if it is there, then we can think it as a adenomatous orogenic tumor. Now for the diagnostic workup, as we have done also for the radicular cyst, we initially do the aspiration of the fluid, and we can see that most of the time the fluid content of the dentigerous cyst is straw color or the brown fluid, and it can become yellowish and suppurative on aspiration if it is infected. Now, the preferred treatment of dentigerous cyst is complete removal of the lesion from the bony cavity by enucleation. So, if we want to save the tooth, then we can go for the marsupialization. So, what we sometimes in present in the mixed dentition, we don't want the premolars to be lost. So, we could do a marsupialization so that if the tooth can be spontaneously erupt and it can be orthodontically guided in the arch. And most of the time, if dentigerous cyst is very large, it could, if you try to go for enucleation, it could damage the neurovascular bundle and it could lead to more comorbidity in the patient. So most of the time, the marsupialization could be less ideal in some of the cases because of the long-standing lesions can become more invasive, such as amyloblastoma or neoplastic transformation of the cyst can happen. This is the drawback with the marsupialization. And apart from that, specifically in the children or adult also, because of the slower healing process, we need to follow up the patient constantly, and the managing the cyst cavity with either with appliance or gauze is little cumbersome to the patient. The recurrence among the dentigerous cyst is very rare, and also in radicular cyst is very rare. So if portion of cyst also remains, it will lie dormant and it will not give rise to another cyst because of the exhaustive nature of the reduced enamel epithelium, because it has already formed the enamel. In contrast to OKC, which is formed from the dental lamina, it has not differentiated and it's more active and has a biological potential to have a proliferate and create more number of recurrences. Now coming to the OKC, the most controversial cyst of odontogenic origin. So it arises from the dental lamina and it accounts for 10% of the cystic lesion of the jaw. 60% of the cysts are the radicular cysts, 18% are the dentigerous cysts, and 10% of the cysts are the OKCs that we come across. And it's more commonly seen in the second and third decade of life. And this cyst contains a high amount of keratin, and when we open up and we can see that it's a thick, cheesy material that comes out of the cyst cavity because of the keratin. And usually histologically it has been is a benign. This lesion exhibits a locally aggressive behavior and it has a very high recurrence rate. Now, pre-2005, odontogenic keratose cyst was treated as a developmental cyst. Then since 2005 till 2017, it has been considered as a keratocystic odontogenic tumor and it has been classified as a tumor. Now, because it was placed in a tumor based on the aggressive behavior, the high recurrence rate, and the patch gene, which is common in tumors observed in OKCs also. So after 2017, we have moved back the OKC into the cyst category, and it also reaffirmed in the 2022 fifth edition of WHO classification. Now coming to the clinical features of OKC, it is more commonly seen in the mandible. That is around 60 to 80% of the cases are mostly seen in the mandible, and among the mandible it has greater propensity to have a lesion around in the molar ramus region. And cysts are mostly asymptomatic and it can cause an expansion, and it can be painful and it causes swelling if the keratin that leaks into the around surrounding tissue can cause a intense inflammatory response. Nerve sensation is not usually affected because it doesn't invade the perineural areas, but it could displace the inferior nerve to the inferior border. Now, radiographic feature of OKC is that it can present in a ways, either unilocular or a multilocular, and margins are oftenly scalloped, or it can be a multilocular, lobulated and distinct. And Large lesion has particularly have a tendency to occur in the mandible around the molar ramus region. We can see in this OPG that there are two large cysts with a septae in the anterior region and most commonly spreading in anteroposterior region, and it involves the ramus mandibular region also. Now, unerupted tooth is seen in around 25 to 40% of the cases, but in mostly in the present when OKC present in the mixed dentition, we could see that most of the time it is always associated with the unerupted tooth. And for the multilocular reducency, we can see that it has a septae that we can come see along with the involvement of unerupted tooth. It can also resolve the bone along with the roots, and if the roots are resolved in a regular and smooth pattern, and inferior border of the cortex are usually maintained, and it has a tendency to follow the medullary region rather than the buccal and lingual cortex. Our diagnostic workup should be first, as you already explained, we should do the aspiration, and while we do the aspiration, we can see the keratin which is dirty, viscoid and creamy, and fluid analysis when we do for the protein content, we can see that it has a less than 4 gram per 100 ml protein compared to that of radicular cyst or dentigerous cyst, which is around 7 gram per 100 ml. So some of you may ask why protein content is more, we are saying because of keratin, but then why if it is less? Because keratin is not a soluble protein. That's why when we do the protein analysis, we can see that there is a less amount of protein in the OKC. Now, histologically, we can have two types of cyst, either parakeratinized or autokeratinized. Parakeratinized is around 80% of the cases are parakeratinized and 20% are the autokeratinized. Parakeratinized have corrugated lumina, and we can see the basement membrane with the reverse polarity, and we can see the picket fan appearance, and there's retipex are not there, and broader cyst we could see. And the problem with the parakeratinized cyst is that it has more tendency to recurrence than that of autokeratinized. Autokeratinized, we have a thin cuboidal cells, and retipex are smooth and lots of keratin in the lumen. And this lesion doesn't have a propensity to recur. And one of the most important features of OKC is that it is most commonly seen in the syndromic patients. And golden gout is mostly associated with the multiple OKCs. It is an autosomal dominant condition because of defective gene, chromosome number 9, which a patch gene. When it does not function, the patch gene, it increases the cell proliferation, and that's why more recurrences and chances of developing OKC. And it usually is seen around 12 to 25 years of age. For the diagnosis of nevat basal cell carcinoma, we should look for the diagnostic criteria, that is presence of two major criteria, one major or two minor criteria, one major criterion or a genetic confirmation. And the most common and the easy thing to see in these patients are the presence of palmar or plantar pits, the bifid ribs, as we can see in the chest X-ray, and presence of basal cell carcinoma around the face, and calcification of the falx cerebri. Now, management of the OKC either can be conservative or aggressive. In conservative, it can be a simple enucleation with or without curettage, marsupialization or decompression. And the aggressive, peripheral osteectomy, chemical curettage with the Carina solution, cryotherapy, electrocautery, and the resection. For the management of large OKCs, we can see in this OPG, there's a presence of large OKC around the mandible posture involving the ramus region. For the lesion on the mandible ramus region with the large cyst, we can see that we can remove the tissue around 1 centimeter and gain access to the cyst lining. We can create a we can create a stoma of around 1 centimeter and stitch the lining along with the mucosa as we have discussed in the marsupialization. Then we can pack with the gauze with the hydroform, and then we can follow up the patient, and the patient is supposed to irrigate the cavity every day, twice every day with a normal saline. And once the patient has been followed around for 10 months, we can see that the radiolucency has been decreased substantially, and now when the radiolucency has remained to around 2 centimeter, then it can again access can be gained, and then total enucleation can be done, followed by the osteotomy and primary growth. The main concern with the OKC is a recurrence, and we can see that with simple enucleation, the recurrence rate is around 43.2%, while with the enucleation along with the Carnot solution, it has a less recurrence rate, that is around 7.9%. When the enucleation was done with the other adjunctive measure, it was high around 25 to 30%, and the least this recurrence was seen with the resection around 6.3%. Now that we have discussed about orogenic cysts, now we are coming to the tumor that are lined by the orogenic epithelium. Now first we will be discussing about the adenomatoid orogenic tumor. It presents as a expansile lesion usually present in the anterior maxilla around the canine, and much of it because of exuberant proliferation in the cyst itself, and it fills the lumen so that it can mimic a solid tumor. And it is also called as a two-third tumor because two-thirds occurs in the maxilla, and two-thirds of the lesion occur in the preteen to teenagers, and two-thirds is associated with the infected canine or premolars, and two-thirds of these tooth are canines. Now coming to the radiographic feature, it also has a well-demarcated unilocular radiolucency like the cyst we have discussed, but the important feature that is distinct from other is that the radiolucency surrounds the entire impacted tooth, and if it is around the CJ, then we must have to think about a dentine cyst. And there is a presence of large dentinoid calcification presence because of exuberant proliferation, and in 50% of the cases we could see the calcification in the OPG or the radiograph that we take. Now histologically it arises from the Herzog epithelial root sheath. It's a well demarcated cyst. It's very cellular with scanty of fibrostoma, and it has a duct-like structure with a cuboidal cell to columnar cells, and when there is a presence of calcification, and it can form a Lees-Gang ring formation that sometimes resemble a dentine or a cementum. Now differential diagnosis can be done based on with radiographic evidence of calcification or without radiographic evidence of calcification. If there is no calcification evidence on a radiograph, then we can think of it as a dentator cyst, OKC, ameloblasttic fibroma, or ameloblastoma. And if there is a presence of calcification in a radiograph, we can think of it as a calcified orogenic cyst, ameloblastic fibroadenoma, ossifying fibroma, and CEOT in cases beyond 14 years. Now, diagnostic workup and management, if when we aspirate the lesion, we can see a straw colored fluid indicative of a cystic in nature. Now, simple enucleation is curative in this adenomatoid orogenic tumor because it has a very thick connective tissue capsule. That's why we can easily remove the cyst in toto along with the tooth, and recurrence is very less, and bony regeneration can be expected. It usually occurs in around 9 to 12 months time. Now the second most common orogenic tumor following the odontomas is ameloblastoma. It is also an tumor of orogenic epithelium origin. Now The ameloblastoma also has a high recurrence rate compared to that of OKC, but OKC doesn't invade the soft tissue, but the ameloblastoma has the tendency to invade soft tissue also, and it can cause a gross disfigurement in the patient. Now, ameloblastoma are divided in three types: solid or multicystic type, most commonly around 86%, unicystic type 13%, and extraosseous or peripheral type, which is merely 1%. Now, the clinical features of ameloblastoma is that it is a slow growing lesion, and usually it is an asymptomatic, and it can expand to a certain level that it can cause a gross disfigurement to the patient, and most commonly is seen in the third molar region of both the jaws, and the lesions around 70% are seen in the mandible, and peak incidence is seen between the second and third decade of life with no sex predilection, and nerve sensation is not altered in the ameloblastoma cases because it doesn't undergo neural invasion. Now, coming to the imaging features of the ameloblastoma, it can either present in a unilocular or a multilocular lesion, and in multilocular lesion can contain a coarse or a bony septate and give the appearance of a honeycomb or a soap bubble appearance. Root absorption, if it's seen, it can be seen as a smooth and regular. Tooth displacement is seen, and displacement of inferior nerve towards the lower border. And in case of maxilla, you can also see a displacement of the sinus membrane. Now, for the differential diagnosis of the ameloblastoma, if there is a radiolucency with presence of mineralization or a radiopacity, then we have to think of it is differential as a autogenic myxoma, calcifying autogenic cyst, calcifying epithelial autogenic tumor also. And in case of radiolucency without mineralization, then we have to think of OKC, central genital granuloma, and pedigerous cyst. Now, based on the histology and recurrence rate and the diagnosis of the lesion, we can see that incidence of follicular and plexiform are the most commonly found ameloblastoma, and recurrence is high among the follicular and the granular cell type. And based on the site, follicular and plexiform is seen mostly in the molar dermis region, acanthomatous type of histological ameloblastoma seen in incisor canine region, and desmoplastic type seen in the maxillary sinus or in incisor segment region. Now, the management of ameloblastoma depend on the cases, whether it is a unicystic, peripheral, or a multicystic one. In case of unicystic or peripheral, we can go for an conservative management, that is a curettage or inoculation with or without peripheral osteectomy. While for the multicystic one, because of recurrence rate, we need to go for a resection of mandible, either in a form of segmental or a peripheral. And adjunctive therapy in a form of cannula solution or cryotherapy can also be used to prevent recurrence in ameloblastomas. Now, the recurrence among ameloblastoma following different treatment protocols, it was found that multicystic or solid ameloblastomas have more recurrence rate, around 41% when done conservative, and it was less for around 8% when treatment was done radically. For the unicystic ameloblastomas, conservative had the recurrence rate around 21%, while the radical had around 3%. The last tumor we want to discuss now is orontoma. It has origin of epithelial and mesenchymal cells of orontogenic origin, and this is the most common orontogenic tumors that we come across in children and young adolescents. And the main chief complaint of the patient presenting with orontomas are failure of eruption or impaction of the incisors, deviation in the path of eruption, or formation of cyst around the impacted orontomas or the tooth. Now, these are two types, either in a compound or a complex. Compound is usually seen in anterior maxillary region, while the complex are seen mostly in the mandible posterior region. The compound occurs at the age usually below 20 years, while the complex occurs usually after 20 years of age. And compound usually resembles the tooth, and they are found in multiple clusters, while for the complex we can see that they form a uniform hard and irregular mass that we see mostly in the mandibular posterior region. Now these are expansile and slow growing, specifically the complex odontoma, while the compound odontoma doesn't have the capacity to grow or cause an expansion. And the treatment of the odontomas, both complex and compound, are conservative surgical evaluation, and they doesn't have a tendency to reoccur. Now, differential diagnosis, we must remember that in case of odontoma, it can be supernumerate tooth such as mesodense, osteomas, or ameloblastic fibrodontoma. To conclude, that the odontogenic cysts and tumors are usually encountered in the pediatric dental practice. So, in order to manage both patient as well as to have an idea how to write an answer on a question regarding the odontogenic cysts and tumors, we can approach with a framework with understanding of the basic understanding of what kind of cyst it is, whether radicular, dentigerous cyst, ameloblastoma, or odontoma, then their clinical presentation, how do they present to us, and its radiographic features. Then based on these radiographic features and a clinical presentation, we can frame a differential diagnosis, and after that, based on the differential diagnosis or a provisional diagnosis, we can write the management that we have discussed. Thank you.
Zin, for your insightful presentation. Are there any question, Dr. Zin? To Dr. Zin?
Thank you, sir. I've checked in the this one chat. There are no questions.
No. I can also see. That's why I'm asking the students. If there is any question, you can directly contact Dr. Rigzin. He will surely answer your question.
I would like
Can
to
we
thank. Sir. Okay.
Can we have the certificate? Okay. Dr. Rigzin, please accept this certificate of appreciation from the ISPPD head office.
Thank you so much, sir. Thank you, ISPPD, organizing committee, Aditi ma'am. Thank you, Manoj sir. Thank you for the opportunity, sir, for this presentation.
Thanks a lot. Thanks a lot, Dr. Rigzin. Moving on to our next speaker and the last session of this rapid revision, we have Professor Vijay Prakash Mathur sir, who is heading the Department of Pediatric and Preventive Dentistry in AIMS. Apart from that, sir has various accolades, like he is a member of WHO on Oral Health Promotions at CDRI AIMS, member of National Center Excellence for Implementation of National Oral Health Program of Government of India. Sir is a Vice President of Indian Society of Dental Research. On international front, sir is the founder, editor-in-chief of Journal of SAPAD, a member of International Association of Pediatric Dentistry, a science committee. Sir has a fellowship of Commonwealth Academic Fellow, Fellow of Indian Society of Dental Research, Fellow of Faculty of Dental Surgery, Royal College of Physician and Surgeon, Glasgow, UK. Sir has published almost 236 papers with a huge number of citations, that is 4,000 and above, and with H index of 36 and I-10 index of 86. Over to you, sir.
Thank you very much, Manoj. Thanks to the organizing team and thanks to ISPPD head office. I request you to play the video.
Okay, sir.
Voice did not come.
Just a minute, sir. Just a minute, sir. We are doing.
Okay. A very good afternoon to this very important and the last lecture of Video Rapid Revision program. I'll be talking to you about preparation for writing a theory paper and appearing in Viva and practical exam with respect to our pediatric dentistry examination. So you should start your preparation 6 months before the exam. Start the focus study about 6 months ahead of the first date of your examination. Plan it in such a way that your curriculum is divided and you can have some time for the revisions at the last. At the time of study, please make notes, review the recent literatures, and make smaller chits or cards which you can review at the time of revision. In between, repolish and examine your preclinical models, workbooks, so that your other preparation goes on. And actually, this will also break your monotony only from studies. You should take help from the colleagues for certain parts for which you are not able to prepare well. They can teach you something or they can share their notes with you. And sometimes for the preclinical models, your workbooks and preparation, you may need help from your colleagues. So do not spend your much time into that and take liberal help. During the preparation, you should stay connected with the family because this is a stress time, and if you remain connected, you feel little less stress. Be participative in the departmental academic activities, works, and discussions. Most of the time, it happens that the last 6 months, whatever seminars have happened, whatever presentations have happened, out of that, there is a likelihood of the questions coming or the questions appearing in the Viva. Read the recent publications. I'm emphasizing once again because these days all the examiners have a tendency to put forward some questions from the recent publications which may be of immediate publication, and talk to seniors who have given the examination recently because they can give you the best tips. They can also tell you where they got stuck, and that experience will help you in doing better preparation for the exam. The further preparation strategies for final exam also says that you have to balance the focus on your theory, clinical, and Viva, all three. You should have a daily structured study plan. At the end of the day, you should see that how much you could do. You should revise the core textbooks and also see recent guidelines. You should practice the clinical case discussions with your colleagues, and mock exam or mock Viva by the faculty or your seniors are also very important component of your preparation. Specifically with respect to theory exam, try to understand the concept and avoid rote learning. Do not mug up everything. Try to make flowcharts, diagrams, and headings yourself so that you are ready with the outline of the writing the answer to the question. Quote the recent evidences and guidelines in your answers, and please see the time management, allocate minutes per minute. The best strategy which I have used during my exams is that I used to read the question first, leave the pen aside, close the eyes for a second, think about the frame of the question, how I'm going to reply that, then start writing. So that makes you refreshed after every question so that you can write the long answers in a preformed way. The high yield topics in our subject are early childhood career, so you need to study them in detail because it is likely that at least 1 or 2 questions or short notes are going to come from these topics. Pulp therapy like epigenesis, epixition, regenerative endodontic therapy, or any component of that is very important. They are likely to have maybe equivalent to half a paper, one of the paper out of the all 4 exams. The behavior management techniques also encompass a large chunk of the paper. Dental trauma is an emerging topic, and nowadays we get many questions on that. And then the preventive dentistry as a core topic in which you have to cover fluoride, topical as well as professionally applied, then the use of dentifrices and patent fissure sealants, all those things, the principles of school, dental health, all those things need to be studied little more in detail. So any question which is a derivation from these can be addressed properly, especially in terms of dental trauma, endodontics. They can be clubbed together in a clinical problem-based question. So you have to prepare these 5 in details, but don't leave the others. The answer writing skills is start with the definition and classification. Use diagrams like tooth anatomy, diagram for the procedures or a flow chart. Add clinical relevance to your writing always, and conclude all the questions with the recent advances. For the practical examination specific preparation, you should practice the case history taking and then present it to one of your seniors. Learn radiographic interpretation. It is not only interpretation which is important, it is actually orienting it properly and mentioning that this is the orthopentamogram of this child covering this area, and maybe if there is additional finding, you should be able to speak that. Demonstration of the clinical procedure is very important, step by step, and following the standard aseptic measures is very important. And lastly, maintain the calm and confidence at the time of treating the patient, that even if it is your exam, finally you are treating a patient who needs you as a doctor. So your calm and confidence is much, much more important during your practical exam. In the clinical case presentations, so out of all 3 or 4 cases which you prepare, you should prepare a structured format as per the relevant to the case in terms of history, diagnosis, differential diagnosis, treatment plan, and anything assistive diagnostic methods which we have used. It may be a test, it may be a radiograph or CBCT, but you should know how to present that, how to taper down to your final diagnosis. During this time, use proper terminology. Do not use the local slangs which you have been using. Use the standard terminology or shorter forms of those. Then, when you come to your diagnosis and your treatment plan, justify your decisions and discuss alternatives. These are all important, which shows that you know the subject holistically rather than bird's eye view. During Viva, please be careful that you have to listen the full question before starting your answer. It is important that you hear out the full question. Sometimes the full question also has a hint for the answer. If you start speaking early, then you tend to lose. Then try to be concise and precise whatever has been asked. Do not go beyond. Like somebody has asked you for an definition, only response up to definition. Do not go to the types or classification further until it is asked. Explain logically that in case you are unsure of your diagnosis, treatment plan, or any of the answer, but explain logically that I know this much, and it's okay if you are not able to answer all the questions. Avoid guessing, avoid doing blind attempts. Try to be frank enough to mention that I'll read it further. Sometimes the examiners will only stop asking you questions when you stop answering. So please do not do blind guessing. It will unnecessarily create a problem for you in answering further questions. For difficult questions, try to break the question into different parts. Think aloud logically. The examiners normally give you time to think and then answer. Relate the problems to the clinical scenario. Do not think in isolation. Stay confident and composed. Most of the times, your examiners will be asking you questions which are relevant to the present situation or present case which you are looking into. So you can handle those very well. They would be in relevance to that. And if it is not in relevance to that, the examiner will normally mention that otherwise leave this case, otherwise what will happen if this happens, or they would give some condition. So handle them properly and be brief. Common mistakes which you should avoid is do not overwrite irrelevant information. Do not do a poor diagram labeling. It should be proper. The arrows should be proper. There should be a very, very clear structure in your answers, and do not ignore the recent advances in any of your answers. So with that, the final revision strategy says that revise your notes multiple times just before the exam. Focus on your weak areas. You may take help from your colleagues. Use flashcards and mnemonics for remembering few things. Many times, if you are more than one candidate appearing, then group discussions will help in preparing better. The final tips is that planning is important, consistency of study is important, being calm and composed at the time of exam and before the exam is very important. Good rest 1 day before the exam is much necessary to perform better. No arguments with the examiners. And remember that one mistake does not ruin your exam. If you continue doing to show off or to accept your mistake, then you are likely to run into problem. So remember, being honest is most important. With that, thank you very much.
Thank you, sir, for this illuminating and well-structured presentation. I hope now the PGs will appear for the exam with the focus, confidence, and clarity.
Thank you,
Thank you,
Manoj.
sir. Can we have certificate of appreciation? Sir, please accept the certificate of appreciation from the highest PPD office.
Thank you, Manoj.
Thank
There
you,
are no
sir.
questions because my presentation was very small and crisp.
No, sir. I mean, it's a inspiring presentation. So, and the topic is when how to go approach an exam. It's very important.
Thank you, Manoj.
Thank you, sir. As we come to an end of this rapid revision program, I would sincerely like to thank to our distinguished speakers for their outstanding lectures and unwavering support. Your contribution were instrumental for the success of rapid revision program, and we will seek this support in the future. Thank you for your and all the PG students who have participated. Even today is holiday. I can see almost 300 students who are attending this program, and the ISPPD members who are attending this program. Thanks a lot. See you soon.